Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former health commissioner here in Baltimore. Our goal is to bring evidence and experience to illuminate critical public health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith-Rogers, producer of Public Health on Call. Today, Stephanie Desmond talks to Megan Christoffeld from JPIGO about the state of family planning around the world as the 2022 International Conference on Family Planning begins in Thailand. Let's listen. Megan Christoffeld, thanks so much for joining me.
Thanks so much, Stephanie. It's a pleasure to be here.
Today, I want to talk about family planning. The International Conference on Family Planning, which is the largest gathering of its kind in the world, will be starting any minute now. And I wanted to ask you really about sort of the state of family planning. I mean, what are we seeing right now?
Yeah, thanks, Stephanie. And what an exciting time it is. I agree. Family planning is what I live and breathe, and so many others who are here are coming to the conference. So these are really exciting times in family planning and a lot of progress, a lot of fresh updates in the field, but it's also a little bit precarious right now with political shifts in the US and around the world that are also creating a bit of a fragile environment for family planning. Maybe just to set the tone a little bit, when we're talking about family planning and making sure your listeners sort of understand what this is really about the ability of individuals and couples to anticipate and attain their desired number of children and the spacing and timing of those pregnancies and births. So that's really what we're looking for. And when we're thinking about family planning and what we're aiming for, what our goals are, it's really a world where every person can attain what I just described, right? Their reproductive goals. So whether that is to have children, to prevent or space their childbearing, or even if an individual is waiting in some ambivalence around childbearing, we're really here to hope and deliver on this idea that the information and systems are equipped and ready to support people in realizing those goals, meeting them where they are over the course of their reproductive lifetimes.
So how well are we doing?
Well, we don't quite have the metrics that tell us whether every person is achieving their reproductive goals. I hope someday we will. That's just not how our measurement frameworks work. But in the meantime, we track a few proxy indicators that give us a picture of performance. So first and foremost, we look at prevalence of modern contraceptive use, right? So at what rate are women of reproductive age using modern contraceptives? And we can look at this over time as well. So the Global Partnership of Family Planning 2030, which is sort of our global umbrella partnership that guides the entire community, they put out an annual report, and they report that in the past 10 years, between 2010 and 2020, modern contraceptive use has increased across Africa and the Latin America and Caribbean region, but it has remained unchanged in Asia and the Pacific. So, for example, in Africa as a whole, and of course that is a broad and diverse continent, but contraceptive prevalence across the continent increased in 2010 from about 21% to 27% or so in 2020. And in the Latin American region, it increased from 52 to 55% over that same decade. While in Asia and Pacific, as mentioned, it remains stagnant at around 46%.
So what you're saying is 26% who want contraceptive have access to it.
Well, what I'm saying here is actually just straight, what is the prevalence of contraceptive use in an entire region? Even putting any kind of need or interest aside, what do we see in terms of absolute numbers? And so just to give you a sense of how that translates, right? Currently that use equates to 357 million women and girls who are using modern contraception in low and middle income countries. So this is, hundreds of millions of individuals using contraception. And just to give you a sense of what that really delivers on, right? That means over just the past year, those 357 million contraceptive users have averted 135 million unintended pregnancies, 28 million unsafe abortions, and 140,000 maternal deaths. So this is, a huge, huge, huge impact that contraceptive use is having, which is really exciting.
And I guess really I jumped the gun, right? So talk to me a little bit about how the demand is being met.
Right. So we definitely want to look at contraceptive use, not just as absolute numbers and rates of use, but really understand to what extent are we meeting the demand of individuals who want to, prevent their next pregnancy or stop childbearing altogether. So the slightly more nuanced take that we do is looking at to what extent is demand for family planning being met. We call this demand satisfied. So as mentioned, we'll now kind of narrow our denominator to those who actually want to prevent or stop childbearing altogether. And if we look at that alone, in low and middle income countries, this demand satisfied indicator currently sits at about between 51% in sub-Saharan Africa to 76% in Middle East and North Africa, with other regions sort of fitting in between those places. So we are seeing some pretty impressive rates of demand satisfied. Also a bit of a ways to go as well. So if you sort of flip that indicator of demand satisfied to who we're missing, we call that unmet need. So unmet need is those who do have an interest to space or we call limit their next pregnancy, but are not currently using any method of modern family planning to do so. And we know that there are over 200 million women and girls in low and middle income countries who meet that criteria, who want to avoid pregnancy and aren't using modern contraceptives. So a big opportunity there.
Why is there so much unmet need?
Yeah, the unmet need, this is so many factors, right? So we're looking at, do people have the products that they can tolerate, that they can live with, that would help them plan their pregnancy? So contraceptives themselves. Do they have services available to them delivered in a way that meets them where they are, right? Whether that is, they're living in an urban setting and their nearby clinic or pharmacy needs to have those materials and counseling in stock, or they're living in a fragile setting and, rely on some humanitarian assistance to get their healthcare services, or, there's a lot of unmet need for a lot of reasons. We also have, of course, sort of social cultural norms that continue to inhibit women and girls' access to basic health care, unfortunately. So a lot of reasons for why that's not happening.
Let's talk a little bit about funding, because I know that that's always sort of the special sauce here. So where are we with that and where do we need to be?
Yeah, thanks for asking, Stephanie. I think this is really top of mind for so many of us in the family planning space, because frankly, funding levels at this point are really insufficient, right? For what we're trying to do in delivering our ability to help individuals reach their reproductive goals. So US government funding, just to start there, for international family planning and reproductive health has been stagnant for over 10 years now. It's hovering at about $600 million per year, which accounts for about 5% of the US global health budget. Of course, fields like HIV and malaria are taking up a much larger proportion of that, also incredibly important health areas. So that's the US contribution. And overall, when we look at bilateral disbursements for family planning per year, those reach about $1.5 billion, largely because of that US contribution, but also due to donors like the United Kingdom, Sweden, the Netherlands, France, Germany, et cetera. But, as I mentioned, these have been stagnant, mostly stagnant over the last decade or so. And of course, in the context of inflation and in the context of a growing global population, what it means is those dollars have to stretch further and further and further to meet those family planning goals and the needs of our global population. Yeah, I do want to mention, I don't think it's only a reliance on donor funding that's the answer. And I wanted to say that there are some impressive modest gains in shifting some of the domestic resource spend. So getting country governments and other local resources committing budgets to family planning is very exciting. And I think we're seeing that trend will hopefully continue due to the work of some great advocates and civil society members. But in the meantime, what it means is this stagnancy could really shift the burden for paying for family planning to family planning users themselves, right? They're going to be shouldering out-of-pocket costs. They're going to be essentially choosing where to put their precious limited funds. And at the end of the day, may not actually have the resources to access family planning or to continue using family planning, right? And this is concerning. We want to make sure that folks have all of their preventative care catered for so that they can live healthy and thriving lives.
So I know that you sort of are excited about what we're seeing in the expansion of different contraceptive methods that are out there. Tell me more.
I am so excited about this. Here's why. We know that for every new contraceptive method that is added to a country's sort of mix of available methods, right? So in their health system, they offer an array of contraceptive methods. We know every time they add a new method, their overall contraceptive prevalence will rise between 4 to 8%, which is really phenomenal when you think about some of those statistics I shared earlier. So it tells us there's a huge opportunity here to add new methods to expand choice and meet individuals' needs in order to kind of increase that rate of contraceptive use and meet the demand of individuals. It also tells us that not all people are currently getting their contraceptive needs met with the choices available to them in the moment. In fact, nearly 40% of women who begin using contraception stop using it within the first year because they're dissatisfied with the method, which is a really understandable situation. I personally have discontinued methods when I went, I do not like this one, right? So it's understandable that this happens. So, it's really worthwhile that we continue investing and innovating around the development and introduction of new products. So, for example, right now, there are major efforts underway to expand access to new and underutilized methods like the hormonal IUD and the self-injected contraceptive. So the hormonal IUD, right? This is well known here in the US as our fastest growing method. But due to pricing and a few other factors, it's taken longer to introduce the hormonal IUD in low and middle income countries. It's finally gaining some traction now. The pricing is less of an issue because lower cost versions have entered the market, which is super exciting. And just personally, I actually am a very satisfied hormonal IUD user. So I'm really excited to see how this method is received as its introduction scales in a number of countries. For example, in Madagascar and Kenya, Zambia, and elsewhere. The other product I think that really has a lot of people's attention right now, and certainly will be discussed a lot here at the International Conference on Family Planning, is the self-injected contraceptive, which is just a game changer. This product, it's called DMPA-SC. I know that's a bit of alphabet soup. It goes under the brand name of Cyanopress, so maybe I'll refer to both here, but it's especially exciting, and here's why. Traditionally, we've had intramuscular injectable contraceptives, so traditional kind of vial and syringe, if you're trying to picture something, right, that have been widely available and utilized around the world, particularly in sub-Saharan Africa. In the US, you might know these products by names like Depo-Provera. But this product, Cyanopress, it's the same hormone, but at a slightly lower dose, and it's packaged into what we call a single-use Uniject device. So it's pre-filled. It comes in this one-time use little plastic device with a short needle, maybe I think it's about an inch long, that needle, which allows the contraceptive to be injected into the fat underneath the skin rather than intramuscularly. And once the injection is complete, the unit can just be safely disposed of. It's injected quarterly. It's 99% effective. And because of the way that it's formulated and packaged, as I'm describing this little unit, it can actually be administered by any trained person. So this might be a community health worker, a pharmacist, a woman herself, not just, the nurse, the physician, right? This is a wide array of people who can do the injection. So an individual can, let's say, take home a year's worth of doses, that would be 4 doses, from her local clinic or her pharmacy nearby, and then control her own contraceptive use, which is going to reduce her time away from home, her time away from work, or just her time away from other activities. And so this has been super exciting for our field to see this scaled up across many, many countries now, and how women are able to take control over this contraceptive action.
It seems like an amazing thing to really put the choices in the hands of women themselves.
Yeah, it really is. And, we're starting to see new models emerge about what it means for how do you coach healthcare workers to coach women? How do you put products in places they've never been before? How do we enable contraceptive use through videos, through, putting things on YouTube to say, here's how to do that injection yourself, which I think is really a game changer. Super exciting.
Terrific. Megan Christofield, thank you so much for joining me.
Thank you so much. I appreciate it.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinell, Spencer Greer, and Matthew Martin with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Holes Fernandez and Amber Bryan Singletary. Thank you for listening.